6:45, so we will go ahead and get started. And Dr. Rosen actually messaged me last night. He offered to introduce you, which I will happily oblige. So I will turn it over to him. But thank you so much for being here.
Good morning and welcome to Grand Rounds. It's a great pleasure and honor for me to introduce Zandy Hillel as our Grand Round speaker this week. Zandy is a very well-established, successful surgeon scientist in the field of laryngology, which makes him a very small number of minority laryngologists that have NIH funding and are moving the field forward from a science, clinical science, basic science perspective. Zandy did his residency at Hopkins, fellowship at Emory, and then went back to Hopkins as has an R01 to support his lab and his scientific investigations, and is also the program director for the residency. Two big major feats. So Zandy, thank you so much. Oh, and factoid for Dr. Muir, Zandy's kids are competitive sailors. Last time I called Zandy, he told me he was in Miami, and I said, "What are you doing in Miami?" He said, "My kids are competing in a sailing event." So for those of you who go to soccer games a couple hours away on the weekends with your kids, Zandy has a whole different experience having to fly to Miami for competitive sailing. So Zandy, welcome and thanks so much for spending time and teaching us.
Thank you, Clark. Thanks for that lovely introduction, and motivates me all the more to come out to San Francisco in the summer for sailing nationals. It's really an honor to present at your Grand Rounds. It's great to see a number of mentors and colleagues. And I really want to recognize Clark because it was through a few discussions that we had that shaped today's presentation to focus on our lab's efforts to develop a drug-eluting stent to treat subglottic stenosis. What I'll share today is really an effort made by a large number of people over the last 12 years to develop animal models to investigate subglottic stenosis. The steps we took to engineer the stent, first in vitro, and then as we move them into our animal models. And then I also want to highlight my clinical experience using stents as part of a endoscopic surgical therapy, the Mattern laryngotracheoplasty, and how success with that surgery gave me the confidence that stents are a viable strategy for ISGS patients, and also how it will inform our steps translating a drug-eluting stent. As I mentioned earlier, science and especially this work is a team sport, and the work I'm presenting today has contributions from many collaborators and mentees that I've been lucky to work with. And then finally, in my last couple slides, I'll briefly discuss a multi-institutional randomized controlled trial that we're hoping to begin in collaboration with UCSF. As Clark mentioned, as we push our field forward using evidence from trials to drive our treatment choices in the field of laryngology. Unfortunately, we're being held up by the NIH freeze, and our hope is that we'll be able to pursue that trial. This is
the rainbow is a division of white light.
I think a patient we can all recognize.
Many beautiful colors. These take
as someone who is having significant difficulty breathing, and it's not just the nasal cannula on her nose as much as it is the fact that she has to gasp for breath every couple of words. And this is what a typical subglottic stenosis patient may look like in the OR, with this individual actually has narrowing at multiple levels, her supraglottis, her subglottis, and as well as her glottis. What airway scar looks like in the OR compared to normal. It's pretty amazing that this was a patient who was able to breathe. And so that's really what I'll be talking about today. These are photographs of what that scar looks like, and I think it does a good job of showing how this very thin lamina propria layer becomes extremely thickened with scar tissue. And the reason why I have these two specimens up is sometimes the disease can involve the cartilage, but more often than not, especially in idiopathic subglottic stenosis, which I'll focus on, the cartilage seems to be spared from disease. When we look at the tissue under the microscope, normal is on the left. You can see the normal architecture of the cartilage, a thin lamina propria, and a thinner epithelial layer. And that contrasts with a fibrotic specimen, where you can see scar tissue, but then there's this layer of immune cells that is just under the epithelium. And it is those are the cell types that our lab has focused on investigating what they are, as well as therapies that may be able to address the immune cells that seem to be driving this process. Stepping back and looking at epidemiology of the disease, you can see from a number of large studies, when we group them together, that the majority of subglottic stenosis is actually caused by our colleagues, placement of breathing tubes. I think that really has come to a head as we came out of COVID, or as we went into and came out of COVID. But there are a couple of other etiologies. Idiopathic subglottic stenosis, which represents about a quarter of all cases, and then autoimmune disease, specifically granulomatosis with polyangiitis. As I mentioned, I'm going to focus in on idiopathic subglottic stenosis, and this is work from one of our collaborators, Alex Gelbhard, and it really helps show that idiopathic subglottic stenosis is a disease that exclusively affects women of Northern European descent. So really a homogeneous patient population. And when I first entered practice, what I noticed was there really was a knowledge gap in our treatment of subglottic stenosis. Some of that continues to today, but I think what we've seen over the last decade is really an advancement in therapy. And that is in part because some of these gaps are understanding in the cellular differences in fibroblasts of normal subglottis versus stenotic subglottis, as well as the interplay between immune cells, fibroblasts, and bacteria has started to be revealed. And we're seeing newer treatments come on that may have some efficacy, such as serial intralesional steroid injections, as well as some newer surgeries that endoscopically remove the scar tissue, some which reline it with epithelium, which I'll talk about, and some which leave little nests of epithelium that seem to overgrow that area that was excised. So I'm going to spend the next few slides talking about how we developed an animal model, a murine model, to study the disease. And that really has been the basis of our research efforts over the last 12 years. And this shows in pictorial form how we used a wire brush to create injury within the trachea. And ultimately, the wire brush wasn't successful alone at causing lasting injury. So we brought in the chemotherapeutic bleomycin, which we took from our pulmonary colleagues who used that to create pulmonary fibrosis in animal models. And that did the trick at creating a lasting model. And what you can see is over a 21-day period, we would the initial acute injury would transform into scar tissue. and then a thickened lamina propria. And when we measured that, you can see the green columns represent the bleomycin and wire brush injury, which maintains its thickened lamina propria by 3 weeks, while the wire brush injury alone undergoes a normal wound healing response and returns to normal thickness. What we then spent some time doing really over the past 2 or 3 years was showing the congruency of this animal model, which is a mechanical model. We're using a wire brush, and showing its congruency to human idiopathic subglottic stenosis. Again, not a perfect model, but a model nonetheless that what I'll show in the next few slides, we feel accurately represents parts of the human disease. What I show here on the left part of this slide is mouse subglottic stenosis with the thickened lamina propria. And on the right, you can see our human specimens of idiopathic subglottic stenosis. When we looked at the epithelial pathology, and I'll reveal why in a future slide, what we can see is ecad heron, which is a barrier protein, as is occludin, and then cytokeratin 5, which is a epithelial protein. You can see in both the mouse and in human controls, you see normal expression of those 3 epithelial proteins. But in the diseased model, we see an absence of those epithelial proteins, even though the epithelium still remains to some extent. And when we look to quantify that, both with gene expression analysis and with protein analysis, what we can see are a significant reduction in these epithelial proteins, CK5, and epithelial barrier proteins. And I'm going to focus on ecad heron. And then what we also showed was that the immune pathology is similar in our murine model as it is in idiopathic subglottic stenosis. I'll focus on IL-17, which we showed is reduced in our, is increased in our diseased specimens, as it is in human ISGS. This is from one of Dr. Gelbard's papers, and you can see the increase in IL-17A within the scar of ISGS patients as compared to controls. So in summary, what we have is a murine model that represents human ISGS. Anatomically, at an immune level, it is an IL-17 driven disease. And then also at the epithelial, within its epithelial pathophysiology. And what this cartoon shows here is our hypothesis as to why ISGS may develop. And what this shows is that in a healthy patient with normal epithelium, that epithelium is acting as an appropriate barrier for antigens that are constantly in the larynx and the subglottis. And that contrasts with our ISGS patient population that has abnormal ecad heron, abnormal barrier function, with the antigens that are allowed to pass through the dysfunctional epithelium and spontaneously stimulate fibrosis in the lamina propria. Again, a hypothesis, but one that when I move to talk about our success with a new surgical therapy that relines the epithelium after shaving the scar out, does support this hypothesis. I'm going to switch gears a little bit now and talk about the immune suppressant drug class of mTOR inhibitors and how we used those, we used drugs in that class to test its efficacy, first in vitro, then in our mouse model, and why we feel it is a good drug that we could actually place into a drug-eluting stent to potentially translate into human use. So mTOR inhibitors are a macrocyclic antibiotic. They are FDA approved for renal transplant patients. And then also they are the active ingredient in a number of coronary artery stents that prevents refibrosis in drug-eluting stents. They've been effective in multiple animal models. And then there are a couple of formulations. There's sirolimus, which is the original rapamycin. And then everolimus, which is a sirolimus analog, which has fewer side effects. This shows our first step into using mTOR inhibitors, and we trialed it on human cells in vitro. And these are just human fibroblasts that were grown in a petri dish. You can see untreated controls, those that were treated with DMSO, which is the carrier for rapamycin or sirolimus. And then at a low concentration of sirolimus, we see fewer fibroblasts, and then at a higher concentration, even fewer. And what the slides below show is the quantitative analysis of those studies. We then translated the use of sirolimus into our mouse model. And what these pictures show are untreated or saline-contreated mice who had subglottic stenosis. And you can see a much thicker lamina propria than those that were treated with sirolimus intraperitoneally. When we compared lamina propria thickness, which is our key outcome measure, we can see significant reduction in lamina propria thickness with sirolimus-treated mice at all 3 time points. And we also see a survival benefit. Again, one of the benefits of using a small animal model is those mice with subglottic stenosis have a shorter lifespan than normal mice, and it allows for us to detect a signal relatively easily with different treatment. And then sirolimus also greatly reduced IL-17, which we are noting as the key immune cell that is driving fibrosis. We then went back to our human cells to see, hey, well, what does sirolimus do to those Th17 cells that we think are driving the fibrosis? And what you can see here, we had fibroblast readouts with collagen-1 gene expression and collagen protein. And when Th17 was given in a co-culture model, you can see a significant increase in collagen production. But once those Th17 cells were treated with sirolimus, we saw a great reduction in collagen reduction. So really showing how sirolimus has that direct impact on Th17 cells, which can then reduce the amount of fibrosis that develops. So in conclusion, subglottic stenosis is an immunologic event, not just a fibrotic one. Th17 cells are driving fibrosis. And the mTOR inhibitor, sirolimus, has both an immunologic anti-IL-17 effect as well as an anti-fibroblast effect that we saw in vitro on fibroblasts. And sirolimus showed a survival benefit in mice with subglottic stenosis. However, systemic sirolimus has side effects. And what I have listed here on the left are some of the reported side effects in kidney transplant patients. And you can see numerous metabolic effects, hyperglycemia, hyperlipidemia. And then this led to a phase 1 trial where we were testing adjuvant everolimus, remember a sirolimus analog, in patients with idiopathic subglottic stenosis. And while it was safe, a few of them developed oral ulcers and had an increased risk of infection. So that was really driving our desire to move into a drug-eluting stent as a safer way to deliver mTOR inhibitors at the site of disease. So we then had to go and design our drug-eluting stent. And luckily, our lab is situated on a bioengineering floor here at the School of Medicine. And so we tapped into some of our colleagues to look at what materials could we use that would release the drug while also maintaining its strength out, at least for the mouse model, for 21 days. And you can see that we ultimately trialed two different materials, and PLLA, PCL actually maintained strength at both initially and out to 3 weeks, while also eluting about 30% of the drug within the stent. That gave us the confidence to at least design a miniaturized version of the stent that we could move into our mouse model. And this is a cartoon showing that. On the next slide, I have a video showing it. Panels E and F are using a silo endoscope in our mice. And here you can see this is what a mouse trachea looks like. And this is what a mouse trachea with a stent looks like. And here is a video of how we place the stent into mice to treat their stenosis. When we tested it against placebo, these are untreated controls, but I have some slides a little later that show a non-drug-eluting stent or a naked stent. What this shows is that the sirolimus stent maintained a patent airway lumen as compared to controls. And again, when we measured it quantitatively with lamina propria thickness, we saw a significant reduction in fibrosis. Similarly, there was a survival benefit in sirolimus eluting stent-treated mice versus placebo. What the dotted line here is this is the systemic sirolimus group, just in comparison, and no real difference between the two. Well, was it the stent or was it the drug that the stent was eluting? So that was the next question we sought to answer. And this is this graph shows what lamina propria thickness was for untreated controls. Those mice that were treated with a naked stent, meaning no sirolimus in it, as compared to the sirolimus. So there really was a benefit from delivering the drug through the stent that we didn't see with the stent alone. And as we saw with the systemic sirolimus, we saw that the local elution of sirolimus also reduced IL-17. You can see it also had an effect overall on T cells as well as macrophages. So our conclusions from the sirolimus stent trials in mice was that there was a survival benefit that had equivalence to systemic sirolimus, and that the stent would be expected to have a lower side effect profile than what we saw when using systemic sirolimus in humans. In my last few slides, I'm going to switch gears, as I mentioned, and share some of our clinical results with a new surgical therapy that really informed our development of a drug-eluting stent. And what I'll present in the next few slides is really how we perform that endoscopic resection. These initial panels show the steps, but I have a few videos where I show the endoscopic resection. And then what this is a stent. It is a T-tube that has been cut down with a split thickness skin graft sutured to the stent, dermis side out, and it's placed into the subglottis and sutured in. This is a 2 nylon stitch that holds it in place. It's placed transcervically. And over the last 9 years, I've performed the endoscopic laryngotracheoplasty on over 20 patients with an 80% success rate. And we define success as they no longer need any operations for their ISGS, and that the scar, basically meaning the scar tissue has not returned. The origin of this procedure, I give all the credit to Mr. Guri Sandhu, who is a surgeon in London. And he named it after the first person he performed it on. She was a flight attendant, and asked him for a resection, but wouldn't allow any incisions made into her neck. Here's a video of our approach. And when I first started doing this, I used a laser to make the cuts down to the cricoid perichondrium, really to establish a depth of disease and create leading edges for the shaver, a microdebrider, to come in and shave out the scar. And here is that microdebrider coming in to shave out the scar. And then the last step is to place the skin graft lined stent into the airway. The stent is then removed 2 weeks later, leaving the skin graft behind in place, very similar to an oral bolster in the mouth, with the only difference is the patient's breathing through the stent for these 2 weeks. And what you'll see here is what it looks like with a skin graft adherent to that area that was excised, and that's the lighter skin. This shows the sequence of surgeries. It's really a series of 4 surgeries. The first is the excision. Then 2 weeks later, we remove the stent. And because the skin graft, and more recently I've been trialing buccal mucosa, because they don't have the cilia hairs that the pseudostratified epithelium of the subglottis has, there's a buildup of secretions adherent to that area in the airway. And so there's 2 subsequent procedures where we remove the secretions and then laser resurface the leg or buccal skin to allow for some overgrowth of pseudostratified epithelium. This is from our publication that Ruth Davis wrote of our first 9 patients. And you can see this shows time to next surgery before the patients underwent this surgery, the Mattern, and then after. And in our first 9, we had 2 recurrences, but 7 of those 9 no longer needed surgery for their disease. When we looked at how they were breathing, we had them measure their peak expiratory flow out as far as 5 years in this paper. And you can see you saw a significant increase in peak expiratory flow, which was maintained out the further they got from surgery. So in summary, we've now done over 20. Most of these patients had short dilation intervals of less than a year. 2 of the patients in that first cohort, but none since, had a tracheostomy at the time that the stent was placed. 1 for laryngeal edema and 1 for cervical obesity, where I was unable to place the transcervical stitch through the skin. Both patients were decannulated the day after stent removal. 17 of the first 21 patients no longer need surgery for their ISGS. And those that failed, I think those are the most interesting ones. 2 had thick posterior scar that I was unable to excise with the microdebrider. 1, I made the mistake of using a nasal septal mucosal graft. And unfortunately, that is erectile tissue. And when they got an infection, the nasal mucosa started to swell and they had airway obstruction. And then in our most recent one, the split thickness skin graft, you know, some of these more recent failures, I wonder how much is it a graft issue. In 1 patient, the graft didn't stick when the stent was removed. And in another, she had a great resection, but then a very thin translucent skin graft. And she recurred within the first 2 months after that surgery. Our inclusion criteria for this is evolving. It still remains idiopathic, but I would consider this for autoimmune disease. Dilation interval, when I first started, I was looking at patients that had less than 1 year between surgeries, but we've extended it as patients have sought out this surgery to treat their disease. And then again, importantly, both the patient and surgeon are willing to proceed to cricotracheal resection. Exclusion criteria, I will look for that dense posterior scar that cannot be shaved out. A BMI of over 40 is another exclusion criteria that I try to follow. So it was really the success with placement of a stent that has informed how we will move our drug-eluting stent into humans. And so what we've been working on is a larger animal model where we can actually test the structure of a drug-eluting stent that could be placed into humans. And what that will require is sort of an inner backbone and then a layer of material that will elute the drug on the outside. And that's what we're working on with a group on our floor, is how do we get that drug-eluting component, that material, to adhere to our firm stent, and then how would we test it? And that's the reason that we developed a sheep model. We first started in pigs, but they have terrible airways when you cut into them. And we anticipate testing our human-sized drug-eluting stents, are actually larger than human-sized because sheep tracheas are bigger, in our sheep. And what this shows is the ability for sheep to survive out to 4 weeks with a stent in place. In my last minute, I just also want to describe what is really a national effort. I mentioned UCSF is part of it, where we plan to leverage the North American Airway Collaborative, which is a collaborative that was spearheaded by Alex Gelbard. And our hope is to build off of his initial trial, which looked at the natural history of idiopathic subglottic stenosis, to trial and intervention serial intralesional steroid injections that are done in office after a dilation to study their efficacy. And the enrolling sites are listed here. And this is really what the design will be, is with 3 steroid injections performed at monthly intervals after dilation in an adjuvant design strategy, with follow-up at 6 months to assess efficacy, really using peak expiratory flow, which I showed as an outcome measure in our Mattern patients. So again, our hope is that the NIH freeze will stop, and that we may hear about that, whether that trial is funded in the coming months. Lastly, I just want to thank just a few people that are on this slide, and it really shows the again the massive effort and the team science behind this work. Thank you.
Thank you so much, Dr. Hillel. Powerful presentation, kind of combining bench to bedside work, very inspiring for many of us. I will moderate some questions. If you have some questions, feel free to throw them in the chat or raise your hand. I'll get us started if you don't mind, Dr. Hillel. I had 2 quick questions for you. The first was, in the phase 1 systemic mTOR inhibitor trial that you guys did you, I know that the primary endpoint was safety, but did you see any difference in the SGS pathology that the patients had? And then it seems like in your research, the mTOR decreases in, Th17 inhibits fibrosis and scar formation. But in the mouse models, they didn't require intervention before applying the drug, and they still had benefit, meaning like they didn't have to remove the scar before you had to do the drug. It didn't have to kind of counteract fibrosis. It was almost counteracting already existing fibrosis. So do you feel like that's an important step in success of this? Like you have to remove that scar, kind of like how you were doing it with the Mattern approach to see benefit?
I feel like I'm going to answer the first question first, or the second question first. I really feel like that's one of the huge benefits of subglottic stenosis, right? When we look at fibrosis in the subglottis, is we can combine surgical therapy with the scientific advances that we're making in say medical therapy. That many of my collaborators are studying pulmonary fibrosis. They don't have that luxury. So similar to the Mattern, I think, where the ability to first excise the scar and then basically prevent it from coming back by promoting epithelial relining is a strategy that will be successful. So you're right, our mouse model not perfect, but it's hard to excise scar in that. I think that's the other reason why we're looking at a larger animal model before we feel comfortable translating a drug-eluting stent to humans.
Got it. Thank you.
And then in our clinical trial, it's funny, similar to how many of us find intralesional steroid injections, there seemed to be a responder group and a non-responder group. And it was one, I'll just be honest, it was a little scary moving to experimenting on humans. And then especially as it was the non-responder group signal that we picked up first, because 4 of the 7 patients actually needed surgery at or earlier than their usual dilation interval. So they were all coming in, and it then took us a little bit longer to note that there was a group of responders to the everolimus, and their dilation intervals have greatly increased. And 2 of those 3 actually haven't needed surgery since they took the adjuvant everolimus.
Got it. Thank you so much, Dr. Hall. We have one question from Dr. Goldberg.
Hi, excellent presentation. Really wonderful work. I put a question in the chat as well. I'm wondering if you have a hypothesis on what the antigen is that's creating the immune response and whether you consider it a dysbiosis or idiopathic response to a microbe.
Yeah, we certainly have, and I give credit to Alex Gelbard, published on the possibility that it's atypical mycobacteria. We're also looking at some viral antigens that seem to be present as a possibility. I don't think we have the answer, but I think there is, whether it's a bacterial antigen or viral, that is sort of a key component of the epithelial barrier dysfunction hypothesis.
Thanks.
Dandy, great work. I was just wondering if you looked at the larynx and the vocal fold motion of your endoscopic Mattern patients and see if the stent placement and all the work that you go through and in and out has impacted the vocal fold motion at all?
We have, and most everybody actually has normal vocal fold motion at post-Mattern. I did recently have a patient who developed a Pseudomonas infection about a week after we removed the stent, requiring intubation. And we got her through that, but she actually developed a unilateral vocal fold paralysis. Whether that was from the stent or a combination of the stent and the infection, I don't know, but she's now 6 or 7 months out from her surgery and hasn't regained mobility. So not necessarily an expected complication. I don't think I've ever had a vocal cord paralysis from an endoscopic surgery before, but a reminder that there are complications. But otherwise, I think to your point, no, we haven't seen a reduction in motion of vocal folds from scar development or from the stent placement.
Dr. Hull, I'd add one other quick question as some others stream in. Do you eventually see combining the drug-eluting stent with the Mattern approach? And do you think that the mTOR inhibitor is going to impact split thickness skin graft uptake? Kind of how do you reconcile those things and think about that?
Yeah, I mean, I think the vision would be for an off-the-shelf drug-eluting stent that can be placed after the scar is removed and is held in place and promotes epithelial regeneration. You know, we're looking into specifically how mTOR inhibitors affect the epithelium. So it may not be that. I think that the mTOR inhibition is going to work to prevent the scar from recurring, and then maybe indirectly allow for epithelial regrowth. I've spoken to Marshall Smith at University of Utah, and he's actually done this surgery but didn't have a skin graft. And he found by leaving the stent in for a much longer period of time, it allowed for that epithelial regrowth over the area that had been excised. So our hope would be to expedite that while the stent is in. But ultimately, I think, you know, I'm going to turn the question back on the laryngologist in the audience. Ultimately, what would it take for you all to feel comfortable placing a stent after shaving out scar in the subglottis, right? How do we get others to adopt this?
Yeah, I think it's super interesting. I mean, I'm interested in the number of procedures that need to be done after that. You know, I think that's the concern for me is placing keratin in the airway and then having to manage it subsequently. So I think that's the biggest, that's been my biggest concern. And I think, moving to buccal mucosa is a super interesting approach, or using some other type of other skin lining or skin related tissue So we didn't have the keratin issue would be, I think, important to me.
Zandy, awesome talk. Thank you. I have a question.
Yue, you just muted yourself.
And
Oh.
before, yeah.
Good morning, Zandy.
Hi,
Thanks for the
Yue.
talk. Awesome. I just have a question about the stents absorption kinetics. I think what I'm imagining is those sinus stents, and as the stent gets absorbed, it fragments. And sometimes, at least in my residency experience, the surgeons had to go back and serially debride it. And I can imagine that being an airway foreign body over time. And your suture, it's not going to, secure all of the pieces as it falls apart. So how do we think about that?
Yeah, that's a great point. And that has kept me up at night. It would be nothing worse than the treatment strategy causing an airway obstruction. Ultimately, I think it would be addressed by having a backbone of a stent that does not degrade, say silastic, and placement of the drug-eluting component, that material on the outside of that stent, similar to how we apply a skin graft now. So
Got it.
ultimately, it wouldn't actually degrade to the point where it could cause airway obstruction.
So then you will go in and remove the non-absorbable part.
Yeah.
I got it. All right. Thanks.
Dandy, is there any value to looking at the stents that IP uses versus, using the components of a T-tube? I don't know if there's pros and cons of those stents.
So the stents that I'm familiar that they use are either expandable or they have those little nubs on the outside of their silastic stents.
Yeah.
And I don't know that those are ideal. I do believe that you have to secure the stent into the subglottis because the proximity to the vocal folds means that it's going to migrate if the stent is placed at the subglottis. But certainly some of their materials, expandable stents could be looked at. And what's interesting about those is that they are not, they're almost perforated, right? Where the material has holes throughout it. And it is the material that releases the drug into the tissue, but doesn't need to be a solid stent. So maybe that might be an option.
Is there ever a problem where, at 2 weeks, the graft isn't adherent, and so when you take the stent out, you take the graft with it?
Yeah, that has happened. And it's with mixed results. There was the one I mentioned that was a failure. But there have been others, especially as I started. I first used PDS to attach the graft to the stent. And the problem is PDS hasn't degraded by 2 weeks. And so I've subsequently moved actually to fast gut to make sure that the skin graft is released from the stent before removal of the stent. I also pass a probe under the graft, but between the stent before removing it to also promote the release of the skin graft from the stent.
So you're dissecting that plane.
Right.
Yeah, that makes all the sense in the world. Because you'd hate to pull that out after all the work you put it, you went in to put it in. Awesome.
Zandy, one last question. You talked about the split thickness skin graft without ciliated tissue and how to go in for those resurfaces. How effective are those resurfacing procedures even with tracheal resections, sometimes that tissue becomes non-functional and patients complain about mucus stasis. Just wondering how big of a problem is it, and does that limit your segment criteria? Like how long, right? That segment you can do the matter.
Yeah, the longest I think I've done is 3 centimeters. And we're actually in the process of contacting all of our patients who have had this to ask them how much they're bothered by mucus plugs. And I think what I would share based on the early results that are coming in is probably about 2/3 continue to be bothered by mucus plugs. Maybe about half of those, so 1/3 overall, are really bothered, and the other third have developed mechanisms. So you're right, it's not an ideal tissue. One option may be actually using something like amniotic membrane, which is used for to resurface after toes are or half a foot is cut off for diabetics by podiatrists and vascular surgeons. And Marshall Smith's actually used a amniotic membrane in 2 patients. I didn't have that confidence, so it's one of the things we'll test in our sheep before bringing it to humans. But so we may actually be looking at alternative tissue sources that may be the answer, rather than buccal mucosa or leg skin.
Awesome.
Sandy, thanks so much. Really, really appreciate it. And congratulations on all the amazing work that you've done.
Thank you, Clark. Thanks so much for having me.
Okay, thank you so much, Dr. Hillel. Someone I think had to sign up for Timber Board, but I really appreciate your talking, receiving messages over text about how inspiring, you're able to bridge so many roles has been. So thank you for coming and really appreciate it. Thank you so much.
Thank you, Michael. Good to see everyone.
Okay, take care.